therapy modalities.
Thank you, Mr. Chairman. So indeed, I will discuss early and late toxicity of radiotherapy for rectal cancer. But by way of introduction, I would like to stress that treatment-related toxicity is very frequently underreported, also because most of these symptoms are usually vague. There are different scoring systems used, which makes it different to compare between studies. We have the prospective reporting of toxicity and a lot of retrospective reporting. We have the patient reporting versus the physician reporting, and we also all know that there is a difference there. Physicians tend to underreport. Toxicity affects quality of life. It requires appropriate treatment. And our rectal cancer patients have become long-term survivors, so we are more frequently confronted with toxicity. What are the patient-related factors? The general condition of the patient is important. Obesity. Obese patients have a tendency for more toxicity compared to normal-weighted patients. Previous surgery before the treatment for rectal cancer is an important factor. We know that the risk of fistula after laparotomy increases to 5% versus 2 to 3% if patients were not operated before the treatment of rectal cancer. And there is an increased risk of small bowel obstruction as well. Diverticulosis is also a risk factor. And then there is diabetes and hypertension, which are both risk factors to develop late treatment-related toxicity. There are the tumor-related factors. The stage of disease is important. The volume of the tumor, the bigger the tumor, the larger the irradiated volume. And lymphatic spread, that's also a tumor-related factor that affects toxicity. If we look into combined modality treatment, we should be aware of the following. So what you see here is a patient that undergoes radiation. Then in the first weeks of treatment, you have the latent period, and there is no damage visible, so it's the subclinical damage. Then some patients develop early toxicity. So you see here the clinical damage. Then you have the recovery phase. But then depending on whether the radiation is combined with another form of cytotoxic treatment, being chemotherapy or surgery, you see that there is a tendency to increase the toxicity related to treatment by a factor of 3 to 4. In radiotherapy, we make the difference between early toxicity versus late toxicity, and we define early toxicity as toxicity occurring during or shortly after treatment, while late toxicity occurs by definition more than 90 days after the onset of treatment. The pathophysiology of early toxicity versus late toxicity is very different. For early toxicity, it is progressive cell depletion and inflammation, and it occurs mainly in the mucosa of the small bowel, the large bowel, and the bladder. So it mainly occurs in the villi and in the crypts, while late toxicity is due to vascular sclerosis and fibrosis, so that mainly occurs in the stroma below the mucosa. Symptoms of early toxicity are diarrhea, cramps, cystitis, perineal dermatitis. Symptoms of late toxicity are bowel dysfunction, fecal incontinence, bleeding and perforation, genitourinary dysfunction, and pelvic fractures. So what is underlying acute toxicity? It is the result of mitotic and apoptotic cell death in the proliferative compartment of the crypt epithelium. And so that leads to a failure to replace the villus epithelium. It shortens the villus. There is endothelial cell swelling and loss with increased vascular permeability. There is a breakdown of the mucosal barrier, and there is mucositis. And all this together leads to the symptoms of acute toxicity. For late toxicity, we see ulceration, mucosal atrophy, vascular sclerosis, focal ischemia, fibrosis, edema, serosal thickening, and this leads to malabsorption, dysmotility, intestinal obstruction, and fistula. So patients with radiation enteropathy present usually 6 months to 3 years after radiation, and they present with abdominal pains, nausea, diarrhea, tenderness. The symptoms are characterized by dysmotility and malabsorption, and this may lead to complications that may require surgery, and this may lead to parenteral nutrition as well, and usually the prognosis of delayed enteropathy is poor. The incidence and severity of acute and late toxicity depends on the radiation dose administered, the volume of small bowel irradiated, the fractionation schedule used, the use of concomitant chemotherapy, the comorbidities, and also observation time is important, especially for late toxicity. What are the diagnostic tests that we can use for late toxicity? We can use imaging, CT, ultrasound. We can measure the intestinal transit. We can do an endoscopy. We can do malabsorption tests, fecal fat excretion, lactose absorption tests, bile acid breath test, or we can also do maldigestion tests with xylose breath test. This is an example of radiation rectitis in a patient treated for prostate cancer. And you see here a radiation ulcer. You see also a fibrotic wall, and you see bleeding of the rectal mucosa. This is a patient with late radiation enteritis. You see the swollen small bowel. You see the edema. You see the bleeding, and also the motility of this small bowel is less compared to healthy bowel. Now, this slide is to explain to you the importance of fraction size. These are two patients treated at MD Anderson a long time ago in the previous century, and they were treated to the thoracic wall with radiotherapy, and this patient had to travel a long distance to the radiotherapy center. So the radiation oncologist decided to treat the patient with 3 fractions of 3.3 gray, while this patient was living nearby the radiotherapy center, and the patient was treated on a daily basis with fractions of 2 gray. If you look at the total dose administered over a week, it is almost the same. Here it's 10 gray, and here it's 9.9 gray. However, and the acute side effects are exactly the same, and the tumor is cured in both patients. However, if you follow these patients years after treatment, you see that this patient develops fibrosis and telangiectasia, while this thoracic wall is perfectly normal. So this is a very nice illustration of the importance of fraction size in the development of late side effects. And this has all to do with radiobiology, and here you see a cell survival curve with on the x-axis the doses, and on the y-axis on a semi-logarithmic scale the surviving fraction. And radiation oncologists all know that tumors have a high alpha-beta value, as have the early reacting tissues, and this leads to this kind of survival curve, while late reacting tissues have a low alpha-beta value, and this leads to this kind of survival curve. And what you can observe here is that if you move to larger doses per fraction, you will kill more cells in the late reacting tissues compared to the acute reacting tissues and the tumor. So that is one of the reasons why we fractionate in radiotherapy, to increase the effect to the tumor and to decrease the effect on the late reacting tissues. And this is another way of plotting this observation, and this is what we call the spaghetti plot, because it was first presented in Rome in 82. And what you see here is the dose per fraction, but be careful, you see the high dose per fraction on the left side and the low dose per fraction on the right side. And here you see the total dose for a certain ISO effect. And what you see is that acutely reacting tissues, they have a flat curve. For instance, the loss of jejunal crypt cells, there is almost no influence on fraction size for a given ISO effect. While for the late reacting tissues, you see that we have very steep curves, skin necrosis, spinal cord paralysis. You see that if you start to increase the dose per fraction, the total dose to obtain a certain ISO effect is a lot lower. So fraction size is very important for late side effects. Now let's then focus on toxicity profiles related to studies in rectal cancer. And for this presentation, I will focus on 5x5 followed by immediate surgery, the randomized trials that we have available, and on chemoradiation followed by surgery, again based on the randomized trials that we have available. So what do we know about 5x5 gray followed by immediate surgery versus surgery alone? Well, we know that with short-course preoperative radiotherapy, we have good results. This is the Swedish trial where we see an improved 5-year overall survival from 48 to 58%. The Dutch TME trial, 5x5, improved 10-year survival in patients with stage 3 disease and a negative circumferential resection margin. And the UK trial, we see that the 3-year disease-free survival was improved with a short course of radiotherapy. But what about the toxicity? These are the data from the Dutch TME trial, early toxicity after 5x5 gray, and overall 26% of all irradiated patients experienced adverse effects, but they were mostly mild. And here you see the listing of the adverse events in the Dutch TME trial, and you see almost the majority of patients had no side effects, few patients had grade 1 toxicity. Of course, we should realize this is 5x5 gray followed by immediate surgery, so there is not much time to develop early toxicity. There is one specific acute toxicity that was observed in treating rectal cancer patients with 5x5 gray, and that was the acute lumbosacral plexopathy that occurs during and after a short course of preoperative radiotherapy. This was mainly observed in the Stockholm trials, but it was also observed in the Dutch TME trial, where a small group of patients developed this very intense pain after a few fractions of 5 gray. So this was already discussed by Jean-Pierre Gérard. Why do we observe more toxicity in the Stockholm and the older trials? That is because of the field size. This is actually an image from the old Fletcher textbook of radiotherapy, and you can see these are the fields that were used in the earlier days, a very high upper border, a low border, and then quite big fields with almost no shielding. This is how most of us treat today. I know that the French people go to even smaller sizes, but what you see here is that the volume is smaller, the upper border is lower, and there is also more shielding used, which leads to less exposure of the normal tissues to radiation. If we look at late toxicity after 5x5 gray, we have the data from the Stockholm trials and from the Dutch trial, and you can see that there is a significant increase in fecal incontinence in the Stockholm trials and in the Dutch TME trial, especially during the day, but also at night. If we look at bowel movements, again, significant increase in bowel movements, except in the Dutch TME trial during the night, there was no significant increase. In the Swedish series, we see more small bowel obstruction, but again, that's probably related to the big volumes that were irradiated with very simple APPA techniques, as this was not confirmed by the Dutch trial. These are data from the UK trial, where you see that there is no significant difference in bowel function with long-term follow-up. This is, of course, with selective post-operative radiotherapy in patients that have had positive resection margins, and the general health in those patient populations is also not significantly different. What about urinary function? Again, in the old trials, we see that there is an increased urinary incontinence in the irradiated group. It's significant, but in the Dutch trial, there is no significant difference between the two groups. But you should realize that in this trial, around 39% of the patients have urinary dysfunction. What about sexual satisfaction? In the Dutch TME trial, when there is an asterisk, it means that there is a significant difference. So at 6 months and 12 months after surgery, you see a significant difference between patients that underwent surgery alone versus patients that underwent pre-op radiation followed by immediate surgery. In the female patients, there is a significant difference up to 2 years after the TME surgery. These are the data in male patients for ejaculation and erection. And here again, you see that there is a significant difference at longer follow-up between patients treated with short course of radiotherapy versus the ones treated with upfront surgery. These are the data for female patients, and here there is no significant difference between the two arms. But you can see that also with surgery, there is significant toxicity. These are the data from the UK trial, where you see that there is a difference in male sexual function at 2 years with a p-value of 0.05. So late toxicity after 5 times 5 gray, we have urinary function, bowel function, sexual function, but we also have other toxicities that were reported, such as pelvic fractures, especially in postmenopausal women. There is also the risk of venous thromboembolism. There is the risk of cardiovascular disease, and there is also the risk of secondary malignancy after pre-op radiotherapy. And here you see data that were published in the Journal of Clinical Oncology, where you see that local recurrence is indeed significantly lower in patients treated with a short course of radiotherapy versus those that go straight to surgery, but there is an increase in secondary tumors, and these are radiation-induced tumors if you compare to the surgery alone arm. The longer follow-up, the 12-year follow-up of the TME trial was recently published, and you see that there is an exactly similar overall survival between the two arms. But if we then look into details, we see that irradiated patients died less often from rectal cancer than the non-irradiated patients, but there were more other causes of death in the irradiated patients. And here you see the listing of all the different reasons that were looked at, and you see that there were more secondary malignancies in the patients that were treated with pre-op radiation. For the other causes of death, there is no significant difference between the two arms. So far, 5 times 5 followed by immediate surgery versus surgery alone. Now we look into the data of 5 times 5 with immediate surgery versus a long course of chemoradiation with delayed surgery. We have 3 randomized trials that directly compare these two regimens. We have the Polish trial, the Australian trial, and the German trial. But for the German trial, we have to wait for the results. In the Polish trial, if we look at early toxicity, of course, what you would expect is that pre-op chemoradiation with a long interval leads to more acute toxicity than a short course followed by immediate surgery. And the same holds for the Australian trial. So indeed, with a long course of chemoradiation and a long interval, we have significantly more early toxicity for pre-op chemoradiation. What about late toxicity? For late toxicity, in these two trials, there is no significant difference between the two arms. What about the addition of oxaliplatin to the pre-op chemoradiation? Well, so far the randomized trials failed to show an improvement in tumor response when oxaliplatin was added to the pre-op regimen, but clearly oxaliplatin increases acute grade 3 and 4 toxicity. And these are all the trials that looked at the addition of oxaliplatin in the pre-op setting. We have the Italian trial, the French trial, the German trial, the US trial, and also the PETAC6 trial. These are all the schedules that were used, and you can see that the dose of radiation varies between the different trials, but also the dose of chemotherapy and especially the dose of oxaliplatin is slightly different between the different trials. Primary endpoint of these trials is mentioned here, and again, the primary endpoints are not exactly comparable between all the trials. But what we see in all these trials is that, except for the German trial, is that there is a significant increase of grade 3 and 4 toxicity in those trials, in those arms where oxaliplatin was added to the pre-op chemoradiation. Also, if you look at the dose modifications, there were more dose modifications needed in the arms where oxaliplatin was added to the treatment, indicating that this leads to more toxicity, which then requires dose reduction. What about the biologicals? Well, there caution is needed with the toxicity patterns, which are very specific usually for these targeted agents, and also for the surgical complications when we combine with VEGF inhibitors or EGFR inhibitors. What are the therapeutic options if we are confronted with late toxicity? Well, we should look at the underlying pathophysiology. If there are nutritional deficits, we can try to correct them with a low-fat diet, with lactose-free diet, with an elemental diet, with total parenteral nutrition. If there is intestinal dysmotility, we can use loperamide or octreotide or prokinetic agents. If there is bile acid malabsorption, we can give patients cholestyramine. If there is bacterial overgrowth, we can give antibiotics. Surgery, only very rarely needed and highly individualized. Usually it's a resection, sometimes it's a bypass, and surgeon needs to be cautious with a side-to-side stapler. What are the future prospects? Well, we should move into the field of highly conformal radiotherapy, and Jean-Pierre Gérard already mentioned the use of protons. There are other ways by which we can individualize our radiation dose distribution. We should also look into the prediction of treatment-related toxicity, because some patients are more radiosensitive than others, and then we can go for an individualized risk-adapted treatment. And we should also look into the toxicity of the new treatment schedules, because they can help us to understand toxicity profiles. And one example is the Rapido trial. This is the design of the Rapido trial. But of course, as was mentioned by Dirk, there are many other trials currently ongoing, and they will probably lead to a different type of toxicity than we are used to with our standard 5x5 or our classical long course of chemoradiation. So to conclude, with the advent of new treatment techniques, we have more long-term survivors, so we have more time to observe toxicity. Treatment-related toxicity in rectal cancer patients is substantial and depends on the type of neoadjuvant treatment and the timing of surgery. Early toxicity mainly includes diarrhea, cystitis, and perineal dermatitis. Late toxicity occurs as bowel dysfunction, fecal incontinence, bleeding and perforation, genitourinary dysfunction, and bony fractures. If we look at the short course of radiation with immediate surgery versus surgery alone, the early toxicity is comparable, but there is more late toxicity with a short course of radiotherapy. If we compare short course with immediate surgery versus long course of chemoradiation and delayed surgery, there is less early toxicity with the short course, and there is a comparable late toxicity. And oxaliplatin and molecular agents so far failed to enhance tumor response but increase toxicity. And what we should not forget is that the worst complication is a local recurrence. Thank you.
Thanks. I pass it on my